All right, well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill, and today I will be serving as your program facilitator. I will help present your questions about the signs, symptoms, and treatment options available for women suffering from heart disease and related conditions. We will discuss a variety of women's heart health topics, including our Cardio-Obstetrics Clinic for patients facing heart complications during pregnancy. And today we are joined by two physicians. Please join me in welcoming Dr. Amanda Roman, maternal and fetal medicine, obstetrics and gynecology at Jefferson Health, as well as Dr. Indrani Rajapriyer, cardiology, heart failure, and transplantation cardiology at Jefferson Health. Well, thank you so much for submitting your questions in advance. And if you have any questions throughout the discussion tonight, for those joining us on their computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. If you don't see it, maybe just try moving your mouse around a bit and it should appear. But go ahead and please select that Q&A icon and you can enter your question in the text box. Your questions are not public. They will only be seen by myself and our panelists. And since this is a sensitive topic, when you submit your questions, you have the option to submit anonymously. And for those joining us by telephone, if able, please go ahead and email any questions to marketingevents@jefferson.edu. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during tonight's virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases or the number of patients we have treated or are currently treating. Likewise, if you are experiencing any symptoms that may require medical attention, please consult a medical professional. Finally, don't worry, we've taken the liberty of muting everyone's line to eliminate any background noise, so feel free to move around and get comfortable. So with that, I want to give each of our physicians a minute to say hello, let us know how you're doing, and then we'll move into our submitted questions this evening. So Dr. Rajapriyer, we'll start with you. Thank you so much for joining us, and how are you?
Thank you, Sarah. Thank you so much for the introduction. I'm doing very well. Good evening to everyone and to all the panelists and the attendees for being here this evening. I'm happy to be here with my colleague, Dr. Amanda Roman, who I work very closely caring for women with high-risk pregnancies. I'm so excited to talk about women's heart health and looking forward to a conversation tonight.
Terrific. Well, thank you so much. And Dr. Roman, we'll turn to you. How are you doing this evening?
Thank you, Sarah, for this warm introduction. I'm doing great. I'm so excited to be to participate today in this webinar with such a large audience. I'm very excited to talk about pregnancy, cardiovascular problems, hypertension in pregnancy. This is such a great topic, and I'm very anxious to hear your questions.
Yes, and I know we've received a lot of them, so let's go ahead and get into it. We will start with question number one. Dr. Rajapriyer, that is coming for you. Can you talk to us about the signs and symptoms of heart disease, and are there any preventative measures that we can take to prevent heart disease?
Sarah, can you hear me clearly? I just want to make sure everybody's able to hear me clearly.
Yes, we can hear you perfectly.
Okay, perfect. So talking about the signs and symptoms of heart disease, I think during the COVID pandemic, we were all afraid and nervous to go into the hospital just because for the fear of contracting COVID-19. I think it's important to recognize these symptoms and signs of heart disease, which I'll be mentioning in a minute. So in order to prevent future consequences or further adverse consequences of developing heart failure. So signs and symptoms of heart disease or heart attack include chest pain, difficulty breathing, dizziness, basically fatigue. These are some of the signs and symptoms of heart disease. Women experience symptoms that are different from men. Women don't sometimes experience chest pain. They feel tired. They could have jaw pain. They could experience nausea. So I think it's important not to ignore these symptoms. We, as women, tend to care for everyone else other than ourselves. So I think it's important to pay attention to these symptoms and seek medical attention. Now, preventative measures to prevent heart disease, there are a few things that we could do that are simple, so we don't have to end up in the hospital. Diet, I think that's very important. Exercise, sleep hygiene, reducing stress. These are some of the things that we could do. I know we don't have time, we get busy with our lives. I think dedicating at least an hour daily or 3 or 4 times a week for ourselves, for exercise, I think would really help prevent heart disease. Exercise decreases the incidence of heart disease, stroke, helps relieve anxiety, stress. So I think these are some of the things that we could do in our daily lives that could prevent heart disease.
Okay. Thank you so much. That is incredibly helpful information. And kind of along those lines, a question we received is, what are the signs of a heart attack and at what point should someone go to the emergency room?
So signs of a heart attack, chest pain, I think that's the number one symptom that people experience, excruciating chest pain that they've not had in their lifetime. Shortness of breath, difficulty breathing, breaking out in a cold sweat, nausea. So I think it's important when you start having these symptoms to call 911. I think trying to drive to an emergency room sometimes delays your care. Time is muscle. This is what I call when you have a heart attack, the sooner you reach the hospital, the sooner they're able to, if you're having a heart attack, take you to the cath lab and open up those arteries and save your heart muscle. So time is muscle, call 911 rather than driving yourself to the emergency room.
Okay. I think that's great. Time is muscle. We'll keep that in mind. All right. Well, thank you, Dr. Raja Prior. Dr. Rowan, let's get to you. A question for you. If medication is the only intervention for high blood pressure and heart disease, which types are safe to take during pregnancy?
Well, we will have to see you. We have to evaluate you thoroughly. So women who are coming to pregnancy with cardiac conditions and high blood pressures, sometimes they're already coming with medication. So we need to select those medications. There are some that are safe and some others are not. So medications like lisinopril, losartan, those are not good in pregnancy, and we would like that you switch to another medication before you get pregnant. So if you have a chronic condition like hypertension or a heart disease prior to becoming pregnant, I want to see you before you get pregnant so I can review your medications and say, these are good, and then call my partner, Dr. Rapreneur, to say, is this okay medication to stop during pregnancy because she plans to get pregnant, so we can switch you to a safer medication, let's say labetalol, nifedipine, things like that. So there are safer medications that we have to take care of you during pregnancy.
Okay, thank you. And I guess as a follow-up question to that, could you talk to us about surgical menopause and if there are any long-term cardiac effects?
Yeah, so either surgical or natural menopause, it will affect you slowly. You sometimes may not notice. The first symptoms that happens in menopause are the hot flashes and the mood swings that are very annoying, but slowly, you don't go into menopause as one day to the next one. It's a slow process that your hormones start going down, down, down until finally there are not enough. So lack of the progesterone produced by the ovaries are estrogens and progesterone. And estrogen is the one that keeps your arteries fluid, moving, pumping well. So when you lose that hormone, the arteries start getting stiffer, your cholesterol can go up, and then you get more stiffness, and then you eventually end up in having high risk for heart attack, hypertension, and things like that. So it's very important that early menopause could happen sometimes below 40, and after 40 anytime. The most common age to have menopause is somewhere 45, 50 and above. So when you start feeling those symptoms, when your periods became irregular, it's very, very important you call your gynecologist to evaluate your hormonal levels and then discuss hormonal replacement therapy that will help you to protect your arteries and lower your cholesterol, and maybe medications to lower your cholesterol, and dietary changes and exercise.
Okay, thank you so much. And Dr. Raja Prior, is there anything you would like to add from a cardiologist perspective?
Yeah, sure. So I think I really what Dr. Roman had suggested in terms of pregnancy and menopause, the recommendations, I echo her. I mean, I agree with her completely. About 700 women each year die due to delivery and pregnancy complications as a result of pregnancy and delivery. And Dr. Roman and I we do a combined cardio-obstetrics clinic in order to help these women so that they do not develop any complications during delivery and have good outcomes. I think maternal cardiac disease is the #1 killer at this time. So we are working very hard to prevent that. And I also, menopause is a big challenge for women in terms of what they go through after in terms of symptoms and also cardiovascular health. As Dr. Roman had suggested, it's important to get in touch with your primary care physician or cardiologist if hormonal replacement therapy is safe for them.
Okay. Well, thank you. And a question, Dr. Raja Prayer, for you, and that we've been receiving a lot tonight, is how important is it to have a healthy, low sodium diet and exercise for keeping your heart healthy?
So I think it is very important, low sodium diet, not just low sodium diet, but a diet. The diet that I would recommend is a Mediterranean diet or a diet that is balanced: fruits, vegetables, legumes, whole grains, dairy, lean meat, fish, poultry. All these are good diet that would help decrease the risk of blood pressure, decrease stroke risk, decrease heart attacks. So a diet that is balanced, and low sodium diet, of course, in patients who have history of high blood pressure and cardiac conditions, a low sodium diet does reduce the risk of complications, but a heart healthy diet and a Mediterranean diet is something that I would recommend. In terms of exercise, yes, AHA has recommended 150 hours a week of moderate intensity exercise. A moderate intensity exercise would be like playing tennis, doubles, or walking at 2.5 miles an hour. That would be considered a moderate intensity exercise, or 75 hours a week of high intensity or rigorous exercise, which would mean running, biking, playing tennis at singles, dancing. So these are things that I think would help decrease the incidence of heart disease and blood pressure and stroke.
Okay. Thank you so much. And funny that you mentioned Mediterranean diet, because that was our next question, but you pretty much answered it. It sounds like people are interested and it's a good plan for a healthy heart.
Yep. Yeah, I couldn't say emphasize enough. That's the best, that's the most studied diet, the Mediterranean diet. I know there are several diets that are vegan diet, the keto diet, but at this point, a balanced diet for those who eat meat and poultry. A Mediterranean diet is one of the best diets that could help reduce cardiac diseases.
Okay, well, thank you so much. I know there's a lot of diets out there, as you said, so Mediterranean diet, we'll keep that in mind. Dr. Roman, okay, switching gears a little here. What can be done during pregnancy so you won't experience preeclampsia that can lead to induction?
Okay, so it is in terms of prevention. So if you have a cardiovascular disease, if you already had a medical condition before getting pregnant, as I said, I want to see you before pregnancy to adjust your medication, have a full cardiology evaluation. Maybe there are things we can improve before you get pregnant. Once you're pregnant, we want to see you as soon as possible. As soon as you have your pregnancy test, call us for first appointment. So we like to start seeing you at 7-10 weeks. So we can see you early and we can evaluate you. To prevent preeclampsia, first of all, knowing your risk factors, and then we have a medication called low dose aspirin. It's an aspirin of 81 milligrams that we want to start in the first trimester, somewhere around between 10 to 12 weeks. So women who had risk factors for preeclampsia, It depends on how the history look like. You will have, let's say, a 10% risk, a 20% risk, or even a 50% risk of developing preeclampsia. So those women is the one that we want to target first and start the low dose aspirin early on in pregnancy and keeping this low dose aspirin for the rest of pregnancy to decrease about 50% of those cases.
Okay, well, thank you so much. All right, turning gears to Dr. Raja Prior now. Can you give us some information regarding diagnosis, treatment, and testing for atrial fibrillation and when to go to the hospital?
Sure. So atrial fibrillation, so the heart condition, you could divide it into several different conditions. One is the electrical activity of the heart, and the other one is the heart pump, which I call it the engine. So the atrial fibrillation is a problem of the electrical system of the heart, where the top chamber of your heart basically is not beating in a normal rhythm. It's just fibrillating, or it's beating at 300 beats per minute. It's not, having atrial fibrillation, you can have symptoms. 30% of people don't have any symptoms. They don't know they're in AFib. But some of the symptoms of atrial fibrillation are palpitations, where you feel your heart is racing, feeling tired. Sometimes atrial fibrillation for a long period of time can result in congestive heart failure. So these are some of the symptoms. Some symptoms of atrial fibrillation can be acute. Some of them could be chronic. It can creep in. So the diagnosis of atrial fibrillation is with an electrocardiogram. You have to be in a physician's office, but some people have their Apple Watch or Fitbit, or some electronic devices that even the iPhone, they're able to give a stat EKG read. So if you have some of those devices, if you feel funny, you can basically check your heart rhythm, and if it's irregular, that's the time to seek medical attention. You can choose to make an appointment with a cardiologist if your heart rate is less than 120. But if you're experiencing, if your heart rate is more than 120, and if you're feeling, if you're having symptoms of trouble breathing, then you should go to the hospital. So there's two ways of dealing with atrial fibrillation. Either if you're feeling symptoms that are really getting worse, then go to the hospital right away. Otherwise, you can seek medical attention with a cardiologist if you're able to get in to see somebody within a week. I think an office visit is also just fine. In terms of medical management for atrial fibrillation, there are two prongs. One is to control the heart rate, and the other aspect of treating atrial fibrillation is to decrease the risk of stroke, because atrial fibrillation does increase the risk of stroke. So there are medications to control the heart rate, and there are also medications to convert you back to normal rhythm. And that's a recommendation that an electrophysiologist and your cardiologist will discuss with you what is the best strategy, whether to get your rate under control or whether to convert you back to normal rhythm. They will also put you on a blood thinner. Now, earlier in the 80s and 90s, we used to have Warfarin, which is usually requires a lot of blood tests, weekly blood tests. Now we have blood thinners that don't even require weekly blood tests to get you, into the range where your blood is thin to decrease the risk of stroke. It's a quick onset of action. With 1 or 2 doses, your blood is thin, and your stroke risk is your incidence of stroke is much lower or comparable to Warfarin. So I hope I've answered all your questions.
Oh, yes, definitely. Thank you so much. I think this is a problem many people face, so appreciate you diving into that for us. We have another question for you, and this is kind of an overarching question for you, Dr. Raja Prior. But does heart disease necessarily have to have a bad ending? And can it be repaired without medication?
So the first question is easier to answer. The second question, I'm not. I think I'm a little biased, but I'll dive into that. So no, heart disease does not have to have a bad ending. I think the field of cardiology has made a tremendous progress since the 70s and 80s, both from how we manage, the medication, people who have heart attack, for example. We are able to get to open the arteries quickly. They don't have any consequences later. We can prevent heart failure. There are a lot of medications, which that's why, I have to talk about medications now. There's primary prevention and secondary prevention. We can talk about, divide it into that. Primary prevention is by diet, exercise, decreasing stress, good sleep hygiene. So yes, you can prevent heart disease and you don't have to take medications. Now, once you develop heart disease, one of the ways to prevent not to have a bad ending is to take medications. I practice heart failure as a field. I see patients who've had hypertension, diabetes for a long period of time and have suffered heart disease and have heart failure, congestive heart failure. And we've come up with these medications that can improve their heart function and even normalize their heart function so that they don't have to have a bad ending, so that they don't have to end up on a transplant list, so that they don't have to get a mechanical pump. So heart disease, again, this field of cardiology, we've made tremendous progress. So heart disease doesn't have to be viewed as a death sentence. We can treat all kinds of heart disease and patients have good outcomes. And medications, definitely, I think the way to some diseases like hypertension, yes, you can, if you exercise, if you have a low sodium diet, people have come off medications. The same thing for the diabetes, unless you have a congenital condition or inherited condition. If you develop diabetes as a result of dietary habits, yes, certainly losing weight, doing exercise, healthy diet, definitely you can come off medications. You can prevent heart disease that way. So I think, yes, medications are sometimes a necessary way to prevent a bad ending, but you could change your dietary habits, exercise, and just your lifestyle, to reverse some of the cardiac conditions.
Okay, well, thank you so much taking those preventative measures. So thanks for walking us through that. Now, Dr. Roman, question for you. Are there any steps you can take prior to trying to conceive to improve your heart health?
Definitely. So first of all, keep a normal weight. So if you're a little bit overweight, lose as much weight as you can. We understand it's not an easy task, so try to do your best. For women who have large amount, they're very overweight, for example, what we call body mass index of 40 and above, and it's very difficult to lose weight. I would say consider to have bariatric surgery. So we have a lot of women who had bariatric surgery. They have lost a good amount of weight, 50, 100 pounds, and their pregnancies are much better than they have in the heavier set. If just try to lose as much as you can, that's the first thing. Second, have a full physical evaluation, look at your blood pressure, your sugar levels, everything, your medical conditions, if you have asthma, if you have hypertension, to change your medications to a good medications during pregnancy that will not increase the risk for birth defects. And as soon as you get pregnant, try to plan your pregnancy. And then as soon as you get pregnant, start prenatal care. So those are the major things we want.
Okay, thank you. And another follow-up question for you related to that. Why is it so important for a patient with a confirmed or suspected heart condition to be closely monitored during pregnancy?
Excellent question. So unfortunately, any maternal heart condition will increase the risk of maternal mortality. So the child, a woman could die during childbirth. And the most common reasons are uncontrolled blood pressure and unknown heart disease. So we need to know you before you get pregnant. And at the very beginning, if you just find out you're pregnant, we want to see you immediately because we need to start treating all these conditions to make your heart in a better shape so you can tolerate pregnancy. Pregnancy is like a marathon. You're not moving, but your heart is racing, you're retaining fluids, every organ is working 3 times more. So if your heart is already weak, mom can get in trouble. And then for those reasons, sometimes we have to deliver the baby prematurely, and then we have the baby also taking problems with prematurity. So we want a good heart.
Okay, thank you. I like that analogy of pregnancy is like a marathon. I think that paints the picture well. So appreciate that. Okay, well, before we take some more live questions, which we've been receiving plenty, so thank you. I'd just like to ask each of you, what are your goals for patients seeking cardiology and cardio-obstetrics? And what do you want our viewers to take away from this webinar? And Dr. Raja Prior, I'll start with you.
Yeah, thank you, Sarah, for that great question. I think one of the efforts Dr. Roman and I are leading is to prevent adverse events, maternal events during pregnancy, and also after delivery and long term. Women who, pregnancy is like a stress test or like a marathon, as Dr. Roman said. So our goal is to identify women and treat women who are at high risk for having cardiac issues during pregnancy or after delivery, and following these patients long term. Dr. Roman will follow them in MFM clinic after delivery, and I see them long term in my clinic to monitor their underlying blood pressure, for example, diabetes. Our goal is to improve care for women, not only during their pregnancy, but after long term, so that they can have a good quality of life for the rest of their life. So my goal and our goal for the Cardio-Obstetrics Clinic is to care for these women and just give them good care, just not for the short term, but for the long term.
Terrific, thank you. And Dr. Roman?
Yeah, so the most important thing is go and see your primary care doctor, be evaluated for hypertension, diabetes, your weight, have your healthcare, your pap smear, your pelvic exam. This is very important to do every year. So if you know you're already in a good shape to start pregnancy, that's a good start. If you had a medical condition, I want to see you before, and I want that my objective is like every month taking a blood pressure cuff at home. It's only $40. It can save your life. You can monitor yourself. You know yourself. So it's important when you suddenly have a red flag, my blood pressure is high, and call my doctor to know what should I do.
Okay. Well, thank you both. Really appreciate you sharing that insight with us. And I think now we are going to turn to our live questions. So we appreciate all the questions coming in, and feel free to keep them coming in as we go through them. But to start it off with, I will turn to you, Dr. Raja Prior. I am over 60 and have been on medication for over 25 years, but my physician recently changed my medication plan. Can you tell me the differences between Cardizodone, HCTZ, and Losartan, HCTZ? And apologies if I mispronounced that.
So it may have been for two different. One reason could be that the blood pressure, if your blood pressure is not well controlled, they may have changed, your physician may have chose to change the regimen from losartan hydrochlorothiazide to candesartan hydrochlorothiazide, because the medications are the same class. The losartan hydrochlorothiazide and candesartan hydrochlorothiazide, it's a pill that has two drugs. One is a diuretic, which is a water pill, the hydrochlorothiazide. Candesartan and losartan belong to the same class of medications. So it may have been that your blood pressure your physician was not satisfied with the blood pressure control with one of these medications and switched you to the other one.
Okay, well, thank you so much. All right, so let's turn to our next question here. Dr. Roman, can you tell us about severe endometriosis and bleeding that can last the whole month? I've had 2 surgeries, but my period has remained the same.
I think it's a difficult question. Unfortunately, endometriosis is a very difficult disease. Sometimes it doesn't go away. You treat it, come back. You treat it, come back. During the reproductive time, sometimes it causes not just heavy bleeding, but infertility as well. So sometimes it's difficult to get pregnant, but unfortunately, the best treatment for endometriosis is menopause, which is not ideal if you're a young person. There are different ranges of endometriosis, and so you need to continue seeing your gynecologist for treatment. Sometimes involves hormonal treatments, surgeries, and unfortunately hysterectomies in some cases, but it is a difficult disease to treat.
Okay, thank you so much. Dr. Raja Prayer, we'll turn back to you for this question. Can you talk about what it means to have a leaky heart valve and what surgical options are available to help me?
Sure. So there are 4 heart valves. You have 2 heart valves on the left side and 2 heart valves on the right side. Most commonly, we deal with leaky valves on the left side of the heart. One is the mitral valve, and you have the aortic valve. So the mitral valves could leak as a result of a congenital condition, which could be what we call a degenerative valves, myxomatous valves, where your valves are not formed and they just degenerate over a long period of time because of the stress. It could leak because of an infection that you've had in the past. It could happen because of rheumatic heart disease or rheumatic fever, which is less common these days. And then you have the aortic valve that could leak as a result of infection or, again, a congenital heart disease, which you had a valve that didn't form right from the time of birth. Now, the options, the surgical options, for the mitral valve, there are 2 options. One, you could have something done without an open heart surgery, which we call the mitral clip. Again, you have to be evaluated to see if you're a candidate for that. And then you have robotic surgeries. We have a surgeon here who does robotic, minimally invasive surgery where you don't have to open your chest or go through a full stenotomy if you're a candidate for that, depending on how your valve looks, or you'll have to go through an open heart chest, open heart surgery to replace your valve or repair your valve. Now, depending on how your valve looks, your valve could be repaired or your valve could be replaced. The durability of valve replacement is much higher compared to valve repair. That's for the mitral valve. For the aortic valve, the only way to fix a leaky aortic valve is to do a surgery. It could be a minimally invasive surgery, which means a smaller incision, or an open heart surgery. However, if your aortic valve is clogged, which means it's not opening well, then there are options where they can do percutaneous, a TAVR procedure, which means you don't have to open your chest. They go through your legs and they have the technology to deploy a valve in the aortic position. They can crush the old valve and put a new valve in. So these are, I think I've gone, these are the 2 common valvular heart diseases that we deal with, the mitral valve and the aortic valve. It's important to know which valve is leaking in order to treat it accordingly.
Okay, thank you so much, and some incredibly helpful information there. So appreciate you taking the time to share. Now, for both physicians, we have a question. So either one of you, feel free to chime in, but a question from the audience: as I approach 70 years old, what kind of heart and gynecology exams should I be having performed each year? And whoever wants to go first.
So from the gynecology point of view, usually we continue doing mammograms up to 70, 75. If you don't have major, if you had a history of normal or no family history of breast cancer, so up to 75, we stop doing mammograms. So still going to your gynecologist. We need to take care of all your menopausal symptoms. When to stop the hormones, the replacement hormones, is up to debate, and it's very important that you be seen by your doctor and individualize your case, because the longer we can give you the hormonal replacement, the better. Your pelvic exam is still needed, because as we grow older, the risk of ovarian cancer increases, so we need to see you every year. We also want to evaluate colon cancer, that increases as we age. And sometimes they come all together in families. So if you have a family history of breast cancer, ovarian cancer, colon cancer, there are some genetical conditions. So if you have one of those, we want to see you every year and evaluate you and evaluate your family.
Okay,
And from a cardiology perspective, an annual cholesterol check to check your blood levels for cholesterol. Also to make sure you don't have diabetes. There's a blood test called hemoglobin A1C if you have risk factors. Those are the two things that I would recommend. And depending on what underlying medical conditions you have, you may get an EKG and a stress test. If you have underlying risk factors for heart disease, which could be high blood pressure or diabetes, or any strong family history of cardiac conditions, or personal history of smoking. These are some of the things that, as Dr. Roman said, individualized care. If you have risk factors, you could do more testing depending on what your risk factors are.
Okay, thank you so much. A follow-up question for you, Dr. Raja Prayer. Sorry to keep you talking here, but we have some great questions. How common of a condition is a leaky heart valve, like we talked about earlier? And is it common for me to have this in my late 50s?
No, leaky valves are not very common unless you have an underlying heart condition. You could have, if I were to do an echo on everyone here, you would find some kind of leakage, which is very minimal. You could get reported, since we have the technology to do the echoes, we are able to find some leaky valves, which are of no consequence. Now, it depends on the severity of the leakage. That's what is more important. It's not very common to have leaky valves unless you have an underlying problem with either your valves or your heart pump. So it's important to know how severe the leakage is. You could have mild leakage, which is of no consequence. So it's important to know that.
Okay, thank you. Another question for you, so don't mute yourself too quickly here, but we're certainly getting some great questions tonight, but one more for you. I have high cholesterol, but I can't tolerate medications. So what options do I have?
So the cholesterol medications, it may be intolerance due to muscle pain, muscle weakness. It all depends on how, again, if you're able to control your cholesterol with diet. In some cases, it's tough because they have a familial condition where they're not able to get their cholesterol down. And there are certain injections that you can do, which doesn't have the same side effects like the muscle pain, which could, you could ask a doctor about that if you're a candidate for that, to lower your cholesterol. Otherwise, I would recommend diet is one way to accomplish that, diet and exercise, to get your bad cholesterol down and your good cholesterol up.
Okay. And as a follow-up to that, we have another diet-related question. So a nice segue there. A question from the audience. I have hypertrophic cardiomyopathy. What are the best diet recommendations for my condition?
So hypertrophic cardiomyopathy is, again, a challenging cardiomyopathy in terms of diet recommendation. Definitely low sodium diet is good for all cardiomyopathy. You don't want to get, when you have cardiomyopathy, you tend to retain fluid and you have trouble breathing, leg swelling. So a low sodium diet is definitely helpful. But in terms of fluid recommendations, it all depends on what stage of your disease process you are. You cannot get too dehydrated. You cannot drink too much fluid because your heart needs some blood volume. You need some blood in your heart in order to increase the forward flow, increase the amount of blood that comes out. So in terms of a diet, it's the standard dietary recommendations that I would recommend for anyone with heart disease. But in terms of fluid intake, it all depends on how you are. You have to figure out your body and not try to get too, if you're, say, for instance, in the summer, you cannot get too dehydrated because you could end up having symptoms. So I think that's one thing I would keep in mind if you have underlying hypertrophic cardiomyopathy in terms of fluid intake. But the diet would remain the same for anyone with a heart disease.
Okay, perfect. Thank you. All right, so we'll turn it to Dr. Roman, give you a break, Dr. Raja Prayer, for a minute. But what kind of benefits, a question from the audience, will I receive as a pregnant woman by visiting the Jefferson Cardio-Obstetrics Clinic?
Excellent questions. You're very welcome to come to our clinic. We care for women who have high-risk conditions, chronic hypertension, heart, problems with the rhythm of the heart. As you heard, there are many of them, palpitations, heart rate going too high, who have had history of preeclampsia, especially if you have had severe preeclampsia that required delivery before 34 weeks. That creates an emergency during your previous pregnancy. We want to see you in this clinic. If you had a history of a congenital heart defect that require surgical repair during the childhood, we want to see you in our clinic. If you had diseases like cardiomyopathy or a weak heart during previously, either pregnant or non-pregnant, this is the kinds of events that we want to see women in our cardio-obstetrical clinic at Jefferson.
Okay, thank you so much. Dr. Raja Prayer, I'll turn it back to you for a situational question we received. I had a big heart attack at 41. I've stopped smoking, lost 70 pounds with surgery, exercise twice a week, and take my medications. How likely is it that I'll have another heart attack?
So since you've changed your lifestyle, you've lost weight, and you're exercising, watching your diet, your risk of another heart attack is very low. As long as you're taking medications, I would recommend not stopping the medications that your doctor has recommended. Definitely with your lifestyle change and taking medications, the risk of another heart attack is low.
Okay. Terrific. Thank you. All right. Another leaky valve question for you, Dr. Raja Prayer. Certainly a popular subject tonight. Is Warfarin the only medication available for a patient with a leaky heart valve?
So it depends. The leaky heart valve, we recommend blood thinners if you have a condition called atrial fibrillation, which is associated with a leaky valve, which we had talked about previously. Especially mitral valve leakage can result in the top chamber of your heart getting bigger, and you could have atrial fibrillation. If you have atrial fibrillation associated with the leaky valve, there are other medications like Eliquis or apixaban or rivaroxaban. There are 2 other medications that you could take. Unless you have contraindications, there may be other contraindications that you cannot take those 2 medications. Now, if you have surgery for a leaky valve with a mechanical valve where they put in a metal to replace your heart valve, then warfarin is only medication that is shown to be beneficial in those instances. So 2 different scenarios. If you've not had a valve replacement and you have AFib, you can use other medications. If you have no other contraindications, but you've had a mechanical valve, then warfarin is the only option.
Okay. Thank you. Now, a question for both of you, but let's turn it to Dr. Roman for a minute. What advice do the doctors have for parents to help their children maintain healthy hearts and healthy bodies, especially if conditions like high blood pressure, long QT, or high cholesterol run in the family?
Definitely, great question. So if you had a condition that runs in the family, the entire family needs to be treated. So when you're on a diet, it's not just one person in the family. Everybody needs to be in that special diet. It's not fun to watch your partner eating something that you can't. So it's better that the entire family improves their diet, their exercise, and decrease weight. So maintaining and getting good habits like do not smoke, do not drink heavily. All those things are very important to do it as a family. So by example, if you do well, your children will do well by example.
Okay, perfect. Thank you. Dr. Raja Prior, turning it back to you now. And thank you again, everyone, for these terrific questions. It's been such a wonderful conversation. But a question from the audience for you: what is ejection fraction, and how long should it take for me to see improvement in that number if I'm taking my medication and exercising and dieting as recommended?
So ejection fraction is a number that we give after looking at the ultrasound of your heart. It really gives us a range. It just gives us a pumping function of your heart. It's an estimate of the pumping function of your heart. That's how I would put it as. The range is, the normal ejection fraction is 55 to 60%. Anything, you could have mild to severe dysfunction of your heart pump, and ejection fraction is used to, decide the severity of your pump function of your heart. Now, this is how I advise my patients. It does take 6 to 9 months when you start taking your medications. Now, there are a lot of medications that have come out that would improve your heart function, ejection fraction. So it takes 6 to 9 months, sometimes more than that, for your heart pump function to return, ejection fraction to return to normal. Now, there are instances where we've seen where the ejection fraction doesn't come back to normal. And that is not, I tell patients that don't get disappointed by that number. Do not get upset. Your ejection fraction went from 15 to only 25%. It's, what counts is that you're able to do your physical activity. You're not ending up in the hospital. You are, you're living your life without having any issues. That means your heart is compensating, it's contracting well, it's meeting the needs of the body. So your ejection fraction is just one number. And I tell my patients, don't fixate on that number because it's going to make you disappointed. I've had patients who live a long time with an ejection fraction of 25%. And they still do very well with medications. So I think as long as you're taking the medications, as long as you're exercising and watching the diet, it's going to be no problem. However, there are rare instances where patients end up getting into trouble, and these are things that you cannot control. But for the majority, if you're taking your medications and you're doing well, you should be okay.
Okay, thank you so much for sharing that. All right, Dr. Roman, let's turn it to you. A question from the audience: do women who experience preeclampsia during pregnancy have a higher risk of heart problems later in life?
That's an excellent question. So there are different kinds of preeclampsia. So there is mild preeclampsia that we can keep mom at home, monitoring every week with blood pressure checks, with listening to the baby heartbeat, monitoring baby's growth, and we can as the disease maintains in a mild range, we can go to term. So this is one. And then there is the severe preeclampsia that gets out of control despite every efforts, and we still have to deliver mom too early because mom and baby are at risk. So there are different risks of recurrence for both of them. At the same time, later on in life, 10 years after the delivery, 20 years after that delivery, we have seen that women with the severe blood pressure, the severe preeclampsia, had twice the risk of heart attacks, coronary artery disease, stroke, renal disease. So if you ever had a preeclampsia, you need to know what kind of preeclampsia, and then see your doctor, your primary care doctor, your cardiologist, because you have down the road a very high risk of cardiac complication. About 10% of women who had preeclampsia have chronic hypertension, so which just adds more problems later on in life.
Thank you. And a follow-up question for you: does menopause affect heart disease?
Definitely it does. So as the estrogen, which is the most important hormone of the ovaries, start waning down, and that happens at different ages, but mostly around 50. If the estrogen comes down, it just makes your cholesterol going up, your the wall of the arteries everywhere in your body start getting stiff. So if that happens in your heart, you have a high risk of heart attacks. So that's why we want to see you increase the risk of coronary disease, of cardiac disease, of hypertension. So we want to talk to you about hormonal replace therapy.
Okay, thank you so much, Dr. Roman. We appreciate it. Dr. Raja Prior, turning it back to you for a minute as we receive 2 questions tonight about heart murmurs. So if I had a heart murmur that resolved itself as a child, does that raise my risk for future heart disease? And is that even considered heart disease, even if I'm not taking medication for it?
Very good question. So if you had a heart murmur that resolved and there was no other associated, if you had seen a doctor and there were no, if the murmur was something that was not going to be of any consequence, or if you had an ultrasound of your heart that showed there was no condition of your heart muscle or your heart valves or anything that resulted in that murmur, no, I would say that there's no issues later on for concerns. If your doctor did say that, you know, if you've had some condition that was associated with the heart murmur, that's certainly depending on what they found, the severity or what the valve, whatever condition they had diagnosed, that it may or may not need follow-up. So the heart murmur itself is not a disease. It's just whatever condition in your heart that resulted in the murmur. If it is something minor, then it should not result in any long-term consequences. However, there are certain other conditions which is associated with the heart murmur, which needs long-term follow-up. So I think it's important to know what caused the heart murmur.
Okay, thank you. Some really interesting questions tonight. So thank you to the audience and thank you, Dr. Raja Prior. Okay, turning it back to Dr. Roman, question for you. I had my tubes tied almost 12 years ago. Does this have anything to do with why my cycle is so heavy in the first 2 to 3 days?
So I don't think so, because the tubes were tied and they're outside the area where it causes the bleeding every month, which is inside of the uterus. So there are fluctuations in life, the hormone changes, and also we can have new conditions. Uterine fibroids, where are like benign masses inside in the uterus. Sometimes they're outside and they don't cause any problem, but if they are facing the inside of the uterus, they can cause heavy bleeding. Things like polyps, things on your cervix. So we need to be sure the pap smear is normal. We need to do a complete evaluation. We can do endoscopy inside of the uterus, ultrasounds, pelvic examinations. We need to know what is causing your heavy periods, if this is something that keeps happening and is not related with your tubal ligation.
Okay, thank you so much. And Dr. Raja Prior, I think we're just about out of time this evening. So one last question for you from the audience before we wrap things up. But okay, I can't get my A1C down, but I've changed my diet months ago. Why might this be?
There are some times where you're not able to get your A1C down with just diet and exercise, and there could be underlying reasons for that. There's insulin resistance, that your body needs help other than diet and exercise, and that's when medications could help bring that down. I'm not sure if you're on medications. If you're not on medications, certainly I know there's always a reluctance to get on medications, but certainly that could help. There are newer medications where you could get your A1C down. Medication should not be viewed as a stigma. If you're able to get your A1C down to prevent damage to your organs like kidneys and heart, certainly you should consider taking medications.
Okay. Well, thank you so much again for the wonderful questions and such an engaging conversation. So as we are just about out of time, as I mentioned, I do want to give an opportunity for any final comments. So Dr. Raja Prior, would you like to start?
Yeah, I would like to thank everyone, the attendees and Jefferson for organizing this webinar. Certainly, women's health and cardiovascular health is a priority for all of us, not just cardiologists, all the primary care physicians, and all the other practicing physicians, because cardiovascular disease is the #1 killer in the United States, even for women. And I think it's very important, it's timely that we all pay attention to our heart health. Cardiac disease is no longer a disease of the older people. Even young people are now getting affected by heart disease. So I think it's very timely that we pay attention to our health, pay attention to if we have hypertension and diabetes, get a control of that quickly so that we don't end up with problems in the future.
Okay, thank you. And Dr. Roman, any last comments?
Yes, if you have any medical conditions and you want to get pregnant, please come to see us as a preconceptional counsel at the Maternal Fetal Medicine in Jefferson. We will review your history, we will do a physical exam, we will evaluate you and prepare you better for a successful pregnancy.
Okay. Well, thank you so much, both. We really appreciate your time. And as we close out this evening, we will be posting a website link that Jefferson is continuously updating with the latest information about the pandemic. We will also be posting a post-event survey, so you can let us know your thoughts. Was this helpful? Is there another time that works better? Any other specialties you would like to hear from? Your feedback will help us bring more virtual events like this to you, the patients. And if there is anything anyone here at Jefferson can do for you in this time of need, please reach out to us. We will continue to offer our wellness webinar series, so please keep checking jeffersonhealth.org for upcoming patient events. And in a moment, we will post those upcoming events with registration links that include the event information and date, so you'll have the opportunity to submit your questions to our panel of physicians. And a recording of this webinar will be available on our website in the next week, so you will be able to rewatch. Well, thank you once again for joining us, and please be sure to stay safe and healthy. We look forward to seeing you soon. Thank you.